Finance Committee will come to order. Today we're going to discuss the scourge of the deadly synthetic opioid fentanyl. Dr. Perrone.
Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for inviting me to share my experiences as an emergency physician in a busy hospital in Philadelphia. Although the statistics we have heard today are dramatic, nothing is worse than facing a parent whose son or daughter has been brought to our hospital after a fentanyl overdose. The struggles of a family battling opioid addiction and navigating the healthcare pitfalls in this chronic relapsing disease are heartbreaking. In the chaos of missed appointments, we recognize that the emergency department can be a gateway to same-day treatment, initiating the first dose of life-saving treatment with Suboxone or methadone. Multiple randomized control studies have built the evidence demonstrating that treatment with these medications can reduce the risk of fatal overdose by 65%. Yet only 11% of people with opioid use disorder receive these medications. Appointments, insurance, transportation, and pharmacies stand in the way. We started a program to provide these medications in our emergency departments in 2018. My colleagues have been trained in prescribing, and our nurses help to identify and support patients to take that step. Tuesday overnight in the emergency department this week at 2 in the morning, I saw 3 patients with opioid use disorder, one who was seeking treatment who was started on methadone, one who had been revived from a non-fatal overdose with naloxone, and one young woman, particularly memorable, who received her first dose of Suboxone and was discharged with a prescription alleviating her withdrawal symptoms and with follow-up to our telehealth program, our peer-led model. I would have liked to have started her on a long-acting injectable medication, but that is not available. This is one aspect of low-barrier treatment, meaning that the patient doesn't need an insurance card or an ID and doesn't need to wait weeks for an appointment or be subject to various scrutiny, all of which can derail early attempts at recovery. Telehealth has now created a critical safety net, more cost-effective than the emergency department and more patient-centered than other care settings. Our Care Connect Warm Line offers free telehealth substance use navigation and same-day clinician appointments to start treatment with Suboxone. We leveraged our peer-led model to staff 9 a.m. to 9 p.m. 7 days a week. We have now treated over 2,000 patients, including 10% of our patients who report release from incarceration in the past 30 days. Implementing this important safety net for citizens re-entering the community mitigates this high-risk period and is critical to closing the treatment gap that patients face when they leave carceral settings. We have also expanded other services for this vulnerable population, including assistance navigating insurance applications, phones, and transportation to future appointments. A Ryan White funding model could be used to establish regional networks of telehealth addiction bridge treatment to prevent gaps in care and continue patients on medication during care transitions. We have found that 2/3 of our telehealth patients were recently on Suboxone, yet were discharged from a care setting without a timely follow-up, or lost insurance, or faced a life event where their care was disrupted. Experiencing opioid cravings without medications drives patients back to the street, only to face the most lethal supply and potentially overdose. Creating low-barrier models such as telehealth bridges enhance retention. Telehealth can also solve long appointment wait times in rural areas due to provider gaps. We must sustain current exceptions to federal regulations for telehealth and create billing parity for these services. Telehealth can also address treatment access disparities. In the Philadelphia area, there's been a 30% increase in fatal overdoses in communities of color since 2020. Fentanyl adulteration of the stimulant drug supply has yielded a new cohort of patients with opioid exposures. Qualitative interviews from our community share that they want more privacy in their substance use treatment options. They don't want to wait in lines outside of opioid treatment programs. We need to focus on developing culturally informed treatment, medication education, and harm reduction tools to address these disparities. Telehealth can help establish care with privacy and then transition patients to a primary care integrated model where patients can receive their addiction care with their hypertension and diabetes medication, all from one trusted provider. Our patients transition from our ED or telehealth visits to our primary care practices. This integrated model needs to be expanded and reimbursed to sustain discrete treatment options. This requires investment in clinician workforce, including expanding addiction medicine training and graduate medical education, and support for expanding capacity for more trainees for addiction medicine fellowships. Our programs utilize the wisdoms of peers like Mr. Vitzina, who build alliances with patients and help them navigate the early treatment journey. Peer training provides a pathway to employment for people in recovery. We must expand these programs by developing billing and reimbursement strategies for these services. Their journeys destigmatize and provide role models to our community members struggling with addiction and are a source of inspiration. People do recover, and we need to share that narrative. Thank you again, and look forward to your questions.
I'd like to go to xylazine. The DEA DEA Administrator Milgram recently stated that xylazine is making the deadliest drug threat to our country that we've ever faced, fentanyl, even deadlier. While this hearing is focused on fentanyl, I'm concerned that the parallel rise in the presence of xylazine and FDA's warning that is undetectable using routine toxicology screens is a problem. How has this co-occurring rise in xylazine complicated your ability to recommend and provide treatment for patients?
Thank you again. Very good question. In Philadelphia, the fentanyl supply has been adulterated with a veterinary tranquilizer called xylazine, sometimes called Tranq, and it has been convincingly impacting our patient population. It's been associated with wounds, really significant wounds, like Mr. Vadzina mentioned about wounds on his arm. We're now seeing a different kind of wounds, and these wounds on patients who are housing challenged really fester and progress, and so that when they finally come to the emergency department, because they have wounds, they actually need to be hospitalized, and then after hospitalization, it's very difficult to send them to rehabilitation facilities because most of the rehabilitation facilities can't accept patients with wounds. So it's a big catch-22 that's limiting our ability to get the most vulnerable patients who need the help the most into treatment. However, I don't want to misguide you. Our deadliest drug is fentanyl. Fentanyl stops people from breathing, and all of the xylazine is accompanied by fentanyl. So we still have naloxone that reverses the fentanyl component, so patients do get revived with naloxone. They may still be sleepy, but they're breathing. So I want to keep the focus on fentanyl as the most important drug we need to focus on. We have one antidote that works incredibly effectively. We don't need 10 antidotes. I don't want to be distracted by all these other drugs coming into the drug supply because it's really mixed with fentanyl, and fentanyl is the deadliest component of all of this.
Thank you. And well said.